Hi there, this is Dr. Jonathan Terry. I am recording this lecture for the St. Agnes Family Medicine residents, but I'm also going to be posting it online in case it serves other folks. So, St. Agnes, you guys know you're my favorites, but we'll see if we can make this worthwhile. I had planned to be in person with you, but I've been asked to help out with interviews during this lecture, so you get a YouTube version. Let's get to the slides. So I'm going to be borrowing our anxiety and panic disorder slides from the ASCP model curriculum for primary care physicians. This slide set was originally by Dr. Pesalo out in Brooklyn. Now, as you can appreciate, anxiety interferes with so many different things in life and work. One of the cases that we'll start off with is a 35-year-old male waste management driver with a long history of asthma and anxiety with panic. That is difficult to, it could be due to many different things, but what we do know is that he's missed work 3 out of the last 12 months because of his attacks. He's had spotty medication adherence, and because of his challenges and missed work, it's caused financial hardships for the family, and he's actually close to full-time disability. This mirrors many of the cases that we might see in primary care. On that note, it's important to mention that up to 85% of patients with anxiety will present in a general medical setting. It can come up at 49% really for any visit. And we do see that primary care physicians have a disproportionate amount of their visits that are related to anxiety. Likewise, it's responsible for emergency room and ER visits. The mental health setting, actually, this is kind of interesting, is that, we're on par about with primary care. And psychiatrists actually, per capita, of course, see less anxiety than a lot of our primary care colleagues do, mainly because there are less of us and because we're harder to access. So anxiety is something that is just so incredibly common and something that many of us will see in practice if we don't bring our own anxiety to our practice. The presenting symptoms for anxiety lead us to workups in all of these different domains. And interestingly, psych is last on this list and kind of the lowest percentage. And I think that that's because it's often a diagnosis of exclusion, right? Patient might come in and they say, hey, I feel nervous, or I feel tension in my face, or I feel numbness. So they might get a workup for central nervous system things. It's very common to see people who have had cardiac workup. They've had an EKG or an echo. They might have GI upset. They notice they have diarrhea. They might notice that they're having trouble breathing, so they go for pulmonary function testing, or they might get worked up for asthma. Often alcohol may overlap and can be comorbid or an independent symptom of anxiety. And then last, as I mentioned, all psychiatric diagnoses by default are going to be our diagnoses of exclusion, meaning that you've already decided that, hey, those palpitations that they're having, it's not because of a cardiac issue, but it might be related to their sense of panic. The other thing that's so important is that somatic complaints, different things related to anxiety, are so important and so costly for healthcare utilization. This relates to the yellow bars, the number of admissions per year, as well as the health insurance costs. And of course, we see that correspondingly where the more a person has somatic complaints, say on a Whiteley scale, the more they are likely to utilize healthcare services. Primary care itself is huge with the utilization for generalized anxiety disorder. And compared to a control group, patients with generalized anxiety disorder or generalized anxiety disorder plus depression are associated with way more visits in 12 months than your average patient. The average primary care patient is associated with less than 1 visit per month, whereas in these cases, we may see closer to 13 or 14 visits over a past 12 months. I think I erroneously said per month. That's of course per year. So less than 1 visit per month, whereas these guys may be in there once a month or more. Now, in terms of a differential diagnosis, anxiety can be just part of the normal human experience. We've all felt anxious sometimes. Might feel anxious when doing a recording for residents. It might be related to disappointment or unexpected news. It could be related to stress. Then we get into what we would call our primary anxiety disorders, where again, these are mostly going to be our diagnoses of exclusion, where we want to make sure it's actually not a secondary anxiety disorder. It's not substance induced. It's not because somebody is having iatrogenic side effects or alcohol withdrawal or benzo withdrawal. Those would all be considered secondary anxiety disorders or related to a general medical illness, somebody with asthma, somebody with thyroid issues. Once we've ruled out our secondary anxiety disorders, then we can get into our primary anxiety disorders, which of course are going to include things like generalized anxiety disorder, panic disorder, OCD, phobias, and PTSD is now in its own category in the DSM-5. However, it was considered an anxiety disorder, as was actually obsessive compulsive disorder in DSM-4 TR and beyond, and before that. So now these have kind of moved into their own categories, but the workup and treatment and the pathophysiology is still a lot like anxiety disorders. We're going to get into now some of the differential diagnosis and some of the criteria for your different anxiety disorders. Generalized anxiety disorder is characterized by excessive worry for more than 6 months and trouble controlling the worry. One of the most important things I think about generalized anxiety disorder is that this is going to be related to reasonable things. It's going to be worries that make sense to you, to me, or to the average patient or the average person. So this isn't going to be an obscure worry about something that may never happen. This is about something that's in the realm of normal. And what happens with those 6 months of anxieties, it's associated then with 3 distinct symptoms, perhaps feeling on edge, fatigued, poor concentration, irritability, muscle tension, and poor sleep. And most importantly, this is not related to a physiologic cause. And we're going to see that over and over. Not related to physiologic cause, not related to substance is going to be super important for a diagnosis of anxiety disorders. One thing I want to point out to you is that if we look at fatigue, concentration, sleep, that sounds like other DSM-5 diagnoses we're familiar with, right? It's going to sound like a bit like our symptoms for a depressive episode, perhaps. So it's going to be really important to tease out what's anxiety, what's depression. Even though our treatments might be very similar, it's going to be important to figure out our different diagnosis for how we might differentiate these patients and differences that we might approach. Panic disorder is exactly what it sounds like. This is going to be our recurrent panic attacks. Now, the difference between a panic attack and panic disorder is that the person with panic disorder is going to be worried about the next panic attack. So you might have a patient who has a panic attack or a second panic attack. You say, hey, are you worried you're going to be having another panic attack? And they'll tell you, well, no, doctor, they just happen. But once you get into 1 month or more of anticipation of the attacks, worry about the consequences. I'm going to pass out. I'm going to lose my job. My girlfriend's going to dump me. All these different things. Now you're looking at panic disorder. And the person has to, it can be, 1 month or more of, so I wanted to look at the criteria here. So as well, behavior changes because of the attacks. Usually this is something like avoidance. They change their behaviors. They don't do something that was making them anxious. And that can be associated with possible agoraphobia, right? Fear of going out into literally the marketplace, the Greek agora, or into social settings. Now, the symptoms of anxiety, the symptoms of a panic attack, are often physiologic. And this is where patients often end up with these incredible workups to figure out, is it something going on with their heart? How many SED rates get ordered on anxious people? How many spiral CTs? Dizziness, lightheadedness, nausea, difficulty breathing, tingling or numbness in the hands, flushes or chills. Catastrophic cognitions. What that means is, a sense of impending doom. I'm going to die from my panic attacks. I've got one patient I can think of right now who's front and center in my mind. She goes to the ER easily 2-3 times a month because she is convinced she's dying. Her panic attacks have been going on for years. They haven't killed her yet. I don't think they're going to. She's more likely to die in the ER or on the way to the ER than from her panic attacks, but she feels that way and it's very serious to her. Fear of losing control, and again, that fear of dying. Let's talk a little bit about some basic facts about anxiety disorder. So anxiety disorder is associated with its onset often in the teens to 20s, but not necessarily. It is a bit more rare, though, for somebody in their 40s and 50s to say, gosh, I've never been anxious in my life, and now I'm anxious. Usually it's a little bit earlier. We see it in children as well, but certainly teens to 20s is most common. It's most commonly female, to the point where actually there's about 2 times the number of women who have anxiety disorder versus men. And the course of an anxiety disorder is that usually it waxes and wanes. So it might be worse for a few months, then it'll go away, and then it might come back. Or a person might get a panic attack out of the blue after they haven't had one in years, if just the situations are exactly right. Family history is important. in that it's very common. Either this could be a nature versus nurture debate. Is it something that's genetic or is it a learned behavior? Kids who are exposed to anxious parents end up having anxiety in their own coping. Um, and the treatment, of course, is that we'll be talking about some different anti-anxiety agents or even, in particular, cognitive behavioral therapy, although there are a number of different therapies that we might use for anxiety disorder. General medical illnesses. Now, we mentioned anxiety needs to be a definition of exclusion, right? It needs to be something that is, we've ruled out all these other things. However, patients with these other things also get anxiety symptoms. And if you're doing a proper diagnosis, if they never had diagnosis or never had anxiety until their COPD and now they're having trouble breathing, it's probably going to be anxiety secondary to general medical condition. And then you qualify that the general medical condition is, say, COPD. So there's a huge overlap with IBS, with stimulant use or intoxication, certainly with both hyper and hypothyroidism, with alcohol or drug withdrawal, menopause, coronary artery disease, or COPD, as we mentioned. In terms of a case, looking at, and this is somebody who I promise you're going to see in your practice, somebody who's almost exactly like this. So you got a 29-year-old male who describes crampy abdominal pain, bloating, diarrhea, gas, food intolerance, especially when they eat in the St. Agnes cafeteria, episodes of anxiety, and they've tried so many different things that don't seem to be getting his anxiety under control. Gastroenterologists love and hate anxiety because you do have the presence of IBS in the US somewhere between 10 and 17%, right? And if we look at patients specifically with IBS, almost a third of them are going to have anxiety. And likewise, about 44% of patients with anxiety may have IBS, even if it's intermittent. So both syndromes do improve with the treatment of anxiety. Now let's think about a little bit about why this might be. Well, one of the things that I like to emphasize, and that you guys will hear me talking about over and over, is how most of our serotonin in the body, I like to ask my patients when they come in with IBS type complaints, okay, where's most of the serotonin in your body? And most will be like, well, it's in my brain because you're giving me the Prozac. I'll be like, well, yes, it's certainly an important neurotransmitter in the brain, but most of it is actually manufactured, transported, and stored in the gut. So it makes sense both that anxiety or depression, a lot of people might have a gut feeling, but also we might see our treatments that involve serotonin often having GI side effects. So loss of serotonergic, and it's an incredibly reductionistic perspective, but it corresponds with both gut symptoms in terms of our diagnosis and our treatment. How about a case for heart disease? Here's one that you might see, again, you're likely to see this case, probably even in the ER. So this is a 42-year-old female who comes in complaining of crushing chest pain. She's had numerous ER visits. She's had in 3 different stress tests, 2 different admissions related to rule out cardiac stuff, and she's had 1 normal cardiac angiogram. She describes herself as being high strung, and she's got a family history of anxiety. Now, the crushing chest pain, usually we don't see that with anxiety. So it makes me wonder a little bit more, hey, are we dealing with something, with an angina case here? But also, turns out when you have crushing chest pain, not only are you going to be anxious when you're having the crushing chest pain, but also in between those episodes of the chest pain as you're anticipating what may be ahead. When we talk about anxiety and cardiac disease, kind of channeling those same thoughts, we have anxiety with true ischemia, and that's actually present in about 50% of patients with ischemia. Of course, they're going to be anxious when they're having that. However, normal coronary arteries is actually responsible for the majority of patients with anxiety. And of course, chest pain itself, chest pain is one of those things that makes you open your eyes pretty wide and feel anxious and maybe go to the ER. Now, one of the other things that actually I'm working with a young woman who's got this going on right now, who's got paroxysmal atrial tachycardia, or any type of supraventricular tachycardia, and she's getting the runaround with anxiety. And the interesting thing, though, is that she doesn't feel anxious between episodes. She feels her heart going, and then she gets anxious. So the chronology is interesting to me. And she's currently actually getting a workup with cards, and she's got the Holter monitor and all that. And they're looking at seeing what the underlying cause may be. But what we do have here, when we do have cardiac issues, is we do have a tremendous amount of misdiagnosis. We have delayed diagnosis, sometimes up in the years, And the resolution of anxiety symptoms is associated with often the resolution of tachycardia, or vice versa. When you treat the tachycardia, if that's something that needs treatment, then the anxiety will also often improve. Now, when we look at the etiology of anxiety in the medical setting, we have to be really thinking as good primary care doctors about having a high index of suspicion, right? Is this just anxiety or is it something else? And we want to see, are the symptoms typical of what we'd expect for anxiety, or are there more somatic complaints? And having a medical history with a good physical exam and maybe some testing can be really useful for helping us discern kind of what's what. Now, in terms of a general medical history, we're of course going to want to do the things that you guys are really good at, noting what medications and substances are used, looking at personal and family histories of heart disease, history of symptoms or thyroid disease, smoking or a lung disease history, menstrual status, and abdominal symptoms. Now, the smoking or lung disease history I think is really interesting because it's hard to have COPD or asthma and not be anxious, right? Our anxiety, and I'll often explain to patients, our anxiety is adaptive. Our body and our brains would rather have us be anxious and alive than not breathing, not awake, and, well, not alive. And I'll explain this to my patients with sleep apnea too, because it's the same underlying physiology. Keeping the heart and lungs going these are going to be the first things that our body has evolved to do. And if keeping us anxious is something that's going to help us, in theory, breathe better, then that's something our physiology is going to set up for us. Now, the smoking thing is really interesting, right? Because nicotine itself and nicotinic receptors, often short term, people might say, oh gosh, I'm just going to go outside and have a smoke to ease my anxiety. The problem is later in the day. So, on the one hand, you have the smoke that's causing inflammation in the lungs, and then you have the nicotine activation and withdrawal, which is going to result in more anxiety. So, most people who are smokers, even light smokers, I will be straight up with them and say, look, as long as you're smoking and whatever you're smoking, it's probably not going to get better until you can really cut back or stop your smoking. Um, so that's something to think about and something that's just so important in our patients with anxiety. You're going to be looking in the medical examination, of course, for pulses, checking heart rate, looking for arrhythmias, things that you would normally do. Also taking a look at skin texture. That could be a way to pick up on thyroid status. It could be a way to pick up on endocrine issues in general. You're going to want to observe the chest, auscultate the lungs, auscultate the heart, palpate the abdomen, sorry, and of course, a mental status exam can be helpful too to document and to think about. And that's something that I harp my students on when they're rotating with me. With the residents, you guys have hopefully been through that on a psych rotation. But documenting a good mental status exam is going to help you down the road for making a case of, hey, is this a primary anxiety disorder or is this something else? Laboratory testing is, in my opinion, if you have access to it, is something that we should do no matter what. And the reason that I say that is because patients will be anxious if they're anemic. They'll be anxious if their thyroid is off. They'll be anxious perhaps if B12 or vitamin D are low. They might be anxious, of course, if they have an infection that we don't know about. Labs are often cheap and available to help us figure some of these things out, whereas things like an EKG might take later priority depending on the symptoms you have. Drug screening can be done on clinical suspicion, same for chest x-ray. So this is one area where from the standardized slide deck, I tend to, if a patient has not had labs to convince me otherwise, I'll try to get at least one good set of baseline labs to help me with my workup. Now, for the acute treatment of anxiety, this is going to be in some ways a little bit different than the chronic treatment of anxiety. And what's first on here I think is so important with the patient education and reassurance. I am not shy with my patients about saying, hey, I've had panic attacks. I've been anxious. It sucks. And here are some things that might help. Or even better, you can turn it into a motivational interviewing type interaction and say, what helps you with your anxiety? What makes it worse? How can we get you to do more of the things that help you? How ready are you for change? Often patients can identify triggers for their anxiety, and this gets into the cognitive behavioral therapy part of it, where being able to identify how thoughts lead to feelings, or feelings lead to thoughts, which leads to actions, which is the premise for Beck's cognitive behavioral therapy, can be so important. Now, medication is something that can be used for anxiety. And we'll talk more about specific types of medicine in here. For the most part in primary care, I want you guys to be avoiding benzodiazepines. There are many reasons for this. That's a lecture all in itself. I trust that we've covered that. But if we're looking at prevention of anxiety, if this is somebody who feels like, they're having anxiety, it's interfering with their daily work or their daily function, then SSRIs are first line, followed by SNRIs. And then way, way, way down the road would we consider other stuff, tricyclics, atypical antipsychotics, mood stabilizers even. We'll talk about those when you can, if you can combine medication and psychotherapy. Medication and psychotherapy is almost always better than medication or psychotherapy alone. So if you have a combination of those things, that's almost always the answer, with the exception of a couple distinct diagnoses that we'll get to in our curriculum. Now, forgive me, these didn't line up on my Google Doc here, but the gist of this slide is saying that cognitive behavioral therapy for panic disorder is effective, and it's effective for reducing panic disorder. These are some of the original studies here. Beck is the original author, if you will, of cognitive behavioral therapy. And CBT essentially, even if you know nothing about CBT, it's really about linking how feelings lead to thoughts, which leads to actions or behavior. So it's a questions of what were you doing when you were anxious? When do you not feel anxious? Gosh, and you get to these things about, okay, maybe the person is only anxious at work, maybe it's performance driven, maybe they hate their boss. All these different things that can be highly relevant. In terms of medications, again, here the slide is just outlining that medications plus therapy is almost always better than medications alone. Now, one of the things that's important, and this data here it's old data, it's from tricyclics, but it works for any of our preventive agents, our primarily serotonergic agents, right? So what we look at in this is that in general, the more months that a person had their tricyclic, or in this case, it's the blue bar, the more time they have in remission essentially between anxiety. So the yellow bar is 6 months on the tricyclic. We can see that there's more relapse there. However, those with longer treatment have lesser relapse and the bars are staying a little bit higher. Now, benzos. In my opinion and in my practice, I almost never use benzos. I inherit people on them, but I'll almost never start them. And the reason I don't like to start them is because I feel like for anxiety, for most people's anxiety, we're setting the patient up for failure. Because every benzodiazepine, pharmacologically and physiologically, is associated with a withdrawal complex, right? And so either we're doing a good job preventing them from ever being exposed to the withdrawal, or we're opening them up to something that's expected. If you do see somebody who's on benzos, though, and many of us do inherit these patients, then it becomes a topic of how do we taper the benzo. And eventually, if you can get the patient off of the benzo, and particularly short-acting benzos like alprazolam or Xanax, you're going to probably improve their anxiety because now they're not having 3 times a day daily withdrawals. So this, again, is a topic all in itself, but it's something that is inherent to anxiety disorder because anxiety might get worse before it gets better as we're tapering benzos. And that's something to make sure that we share in the governance and discuss that with our patients. Again, let's see, this we saw already with healthcare utilization. Anxious people use a lot of healthcare services. Now, let's talk a little bit about pharmacotherapy. So benzos, in general, have the following properties in order across the class. They're both sedatives. They can be anticonvulsants. We know we use them in acute epilepsy, often through IM forms, and they are muscle relaxants. So you can appreciate how all these things would subjectively help with getting rid of anxiety. And maybe the patient that I would consider a benzo in is the one who has like a really rare and predictable panic attack in a controlled environment. So maybe, again, there are better agents for this. But for your patient who's going on a flight and flying makes them really anxious, maybe you can give them a dose or two to get them there and back. But again, they need to maybe a trial dose to make sure they can get up and off the plane. But again, due to dependence, I want to be really careful about how much we're using these. Seeing if there's anything I want to speak here, because a lot of this has old information about barbiturates and older classes. Benzos in general are certainly safer than barbiturates, but because of the abuse potential and the higher LD50, ED50, we really, would prefer not to use them at all because we do have safer agents. Not necessarily more effective agents, but safer long-term agents, and we're always thinking about safety. Since the introduction of benzos compared to older drugs, and this is important, the number of sleeping pill-related suicides and accidental deaths have decreased. But we do have, still a lot of ER visits related to benzos. So it's kind of like, um, it's robbing Peter to pay Paul, or uh, picking just something that is still pretty harmful. And again, the older agents, you guys are not, I don't think, almost ever going to be prescribing these. So I'm going to not spend a lot of time with them. Now, clinically significant dependence can occur at therapeutic doses and more rapidly with high potency short acting benzos. So if you were to look at what is called a benzodiazepine equivalency chart, you can get an idea for the half-life of a benzo. And the ones with the shortest half-lives, like alprazolam, triazolam, are going to be associated with higher potency, higher risk. Now, that said, those that are reinforcing, like clonazepam or diazepam, where you feel the onset come on and you just feel so relaxed, those are also associated with psychological dependence in terms of the patient realizing, hey, if I don't have this medicine, I am going to have a panic attack. Doctor, I need more medicine. Best if we can prevent that from the start. Benzos, this slide is basically saying, benzos are still widely prescribed, even though in general we do see declining use of them. And now, of course, in California, you do need to check a cures report. You need to, it requires a lot more documentation, requires more monitoring. It's more work for you and the patient. The bias of this slide set, and they do have a point, I think, is that in general, serious risks may be exaggerated. But again, in my opinion, it's easier to entirely avoid the topic because there are many non-benzo agents you can get to first, and we'll talk a little bit about that. Especially if a patient is using alcohol, if they're using any illicit drugs, you want to be really careful with benzos. Benzos do have a nice street value, so especially if you do have a patient who is pursuing these as an additional source of income, and I see it often in my practice, that's also something just to be mindful of and have that talk with your patient about the appropriateness and safety of that. We talked about how alprazolam or lorazepam does exist for short-term dependence. They shouldn't be withheld because of prejudice or misconception. I agree with that. However, we can try other agents first. And if we can, meet the needs of 80 or 90% of patients with anxiety without using a benzo, it makes sense to use something else first. So in terms of the rational use of benzos, at least according to this slide set, might include, the presence of a benzodiazepine responsive syndrome like anxiety, using appropriate non-pharmacologic therapies, which in my opinion should be always, assessing the appropriate duration of treatment. So having a controlled substance agreement with patients where you're saying, look, we are only going to prescribe it for this amount of time, and having that expectation being very clear and ideally in writing. Don't using them open-ended for insomnia, but instead switching to another agent if you are looking at doing more long-term intervention, either for anxiety or insomnia. I do like this here about considering the risk-benefit ratio for individual patients. So of course, if there's active substance abuse, probably not the best. However, for some patients who are highly responsible, high performers who have failed less risky means, benzos might be reasonable at that point. So I would structure these to say as like maybe a third or fourth line agent in how I'm going to think about treating just about anybody with anxiety. We're also going to talk about some of these other pieces here as we get through the talk. And things that we've already discussed a little bit, slowly tapering the benzo after an appropriate trial. And now if they have anxiety when they come off the benzo, you've got a new problem, right? Is it physiologic or psychological withdrawal, or is this the underlying anxiety that you never treated because you slapped a Band-Aid on the symptoms? So sometimes benzos will buy us time. Sometimes they might get a person out of the behavioral pattern of having anxiety, and they might cause more problems. I'm going to cruise over this topic of choosing a benzo and focus more on general factors in terms of, avoid the short acting options as we've discussed. Most psychiatrists in 2020 will never prescribe alprazolam because we see the risks far outweigh the benefits. And some of the stuff I disagree with, so I'm gonna keep going here. Just some general stuff for your test for benzo. Benzos do act through the GABA A receptor, and it's a ligand-gated channel. So we do have some wonderful biochemistry and physiology here. There's something else, that, however, that is a GABA A agonist besides a benzo. And if you said alcohol, or if you're watching this lecture online and you raise your glass of whatever it is you're drinking, then GABA A is something else to keep in mind. So I'll tell patients that, especially for the ones who, are having a shot to go to sleep at night or something like that, effectively they are prescribing their own benzodiazepine. Oh, I guess one thing that's important here in general, and this is something to think about, is antacids in general will interfere with absorption for a lot of our meds, not just benzos, but that's something to keep in mind if you have somebody who changes their benzo dose. And let's say they take their antacid or their H2 blocker or something at one time during the day, they might consider dosing the other meds at another time. I'm going to skip over sublingual and IM use of benzos. I think, and certainly IV use, I feel like that's outside the scope of this talk. And same thing, if you have somebody inpatient with anxiety, usually there are many things you can offer besides benzos, especially if you're concerned about cognition, if you're concerned about agitation, and certainly if you have a patient who is delirious, you don't want to be using benzos. I do think one of the exceptions to the rule, of course, is for operative sedation and in epilepsy, as is documented here. Now, the side effects of benzos are one of the reasons why we talk about them in pretty good detail in this lecture. So sedation and impairment of performance are huge. Again, remember, this medicine is effectively working in the brain the same as alcohol. So you might have somebody say, oh gosh, I've got this big, speech to give. I've got this big public speaking deal or whatever. And you can ask them, okay, is that something that you would take a shot before you did? And they say, well, no, I want to be on my A game for it. Okay, well, likewise, taking, Xanax or an Ativan probably isn't going to be best for you at that time. So the performance impairment is important. Memory effects. So acute dosages of benzos may cause anterograde amnesia, or the inability to acquire new information. Interestingly, if you think about long-term alcohol use and Korsakoff-type dementia, it's also associated with anterograde amnesia. And there's increasing evidence that long-term benzo exposure can make this more of a problem cognitively. And this is independent of sedation. So if you have somebody who is, say, a patient with a history of a TBI, or just bad metabolic or brain health in general, you might have more cognitive and memory problems than you would in a brain that doesn't have those same issues. Benzos can also cause disinhibition. This is something I think about in patients, say, who might have intermittent explosive disorder, antisocial personality disorder, anybody who is prone to rage or impulsivity. Benzos aren't going to help with that any more, again, than a shot of some type of alcohol is going to help with that. Now, another thing, just like alcohol is a depressant, benzos are depressants as well. So they have been associated with the worsening of depression. So if you have a patient with depression and anxiety, as these cases often are intertwined, thinking about a benzo in this case is adding a depressant to a person who's already depressed. So that's another potential and in my book, contraindication for doing so. We talked in detail already about the advantages and disadvantages, and I'm kind of cruising to try to get through the slide set here in my about 45-minute block I have with you. This gets into the dosage of benzos. You'll look that up anyway when you're doing this. The important thing I think to put out here is not so much the benzo daily dosage here, so much as, again, this benzo equivalency chart or benzo equivalency table. And there are a number of them that you can look up. But what I want to point out here is, let's say that you have a 0.5 milligram of alprazolam. Well, that's about the same as 5 or 10 milligrams of diazepam, or half a mil. Clonazepam's pretty close, but lorazepam about 1. So if it's somebody who, especially like with alprazolam, you might say, oh, well, they're only getting 3 milligrams a day. Well, that 3 milligrams is equivalent to a lot, to 6 milligrams of lorazepam, which is a huge dose. Or depending on how you count it, 6 to 12 drink equivalents per day. So that's huge when you're considering how much a person is getting. More on the equivalents. This is kind of interesting. I don't know what to make of this. I'm going to skip this slide. Let's talk a little bit about buspirone. Now, buspirone is frequently confused with bupropion. They are very different drugs. Bupropion has nothing about it that's serotonergic, whereas buspirone is a serotonin agonist. Buspirone is indicated for generalized anxiety disorder. And it's interesting because it doesn't separate well from placebo. Here, clinical studies suggest buspirone works, but if it was that good, it would be our #1 choice. It doesn't separate well from placebo, but it did have, the 2 positive studies required to pass FDA approval. So I like buspirone as something that's serotonergic if that's not a risk for the patient. It can be prescribed with antidepressants, of course, monitoring for serotonin excess. Some patients do well with buspirone and on an as-needed basis, even though that's not FDA approved for that. So what I think of buspirone, because it can be dosed up to 3 times daily, is you have patients who might need that reinforcement. They need to take something 3 times a day. Great, give them 5 milligrams of buspirone. The maximum daily dose is 60 milligrams divided 2 or 3 times daily. So you can decide how to figure that out. But it's a nice option for somebody who has to take something to slow down their anxiety. Now, this is one potential treatment scale for buspirone. I like to go with whatever the patient wants and needs, because again, some people may get by on 5 milligrams once a day because they need to take something, and that's great. It's not FDA approved to work that way, but it's easy to use that way, and it's relatively safe. Sometimes minor problems associated with, with any time we're messing with serotonin, headache, nausea, dizziness, maybe some increased tension and agitation. Be mindful of that, especially if you have any concerns about bipolar type stuff. And buspirone certainly has less discontinuation syndromes than our SSRIs, venlafaxine. And that's interesting, there's paroxetine here, which is an SSRI, but whatever. So buspirone, again, like, it's not a robust drug, it's not a sexy drug, but it can be reinforcing, it can be helpful. And some patients, it's the miraculous thing that does it for their anxiety. This differentiates kind of, again, poor formatting. Here's the dividing line between benzos and buspar. The kick here is that there's many reasons to use a buspar instead of benzos for most patients. Now, as we get into our antidepressants, and this says GAD, but in general, as you're thinking about your antidepressants, your dosing is going to be a little bit higher than for depression. Not always, sometimes it'll overlap. But you'll notice here, like, we see up to 60 milligrams of fluoxetine. Sometimes I see people go to 80. Sertraline, for especially like as we get into obsessive compulsive disorder and panic disorder, you might really be pushing 200 milligrams, maybe even above that. Certainly okay to refer to a psychiatrist if you want to look at that. And here we do have some data on what's a controlled trial and what is FDA approved with, the 1 star versus 2 stars. We do a lot of things off-label in psychiatry, and if a class works, we'll probably stick with it. TCAs, I'm going to skip for now because we should talk about those separately and not in the context of anxiety. I would not often use a TCA for anxiety unless I was using it for something else, for neuropathic pain, for sleep, for migraine prevention, that sort of thing. This next slide talks about venlafaxine and the SSRIs in general and we'll extrapolate this to all anxiety disorders. But SSRIs in general are effective. They're relatively safe for them, even though we do have some discontinuation syndrome. We don't have the issues with dependence. Most can be easily dosed once a day. But again, they do have all the side effects that we're familiar with our SSRIs. In particular, sexual side effects, dose titration, delayed onset of action. If I'm anxious today, I don't want to wait for 4 weeks from now. Um, and they may make folks a little bit more anxious right when they're starting. Usually, this would result, or I'm sorry, in the past, people would prescribe benzos along with starting an SSRI. Now we frown upon that practice for all of the reasons that we've spoken about. These are the SSRIs that are approved for different anxiety disorders. And again, even though the slide says SSRIs, venlafaxine is not an SSRI, nor is duloxetine, nor is desvenlafaxine. But roll with me here. Anything in the SSRI or SNRI category is going to be used either on or off label for your different anxiety disorders. For anticonvulsants, I want to ignore almost all of these except for gabapentin in particular, because gabapentin does show good evidence for treatment of anxiety. Sometimes you have to get it up to pretty high doses, but it's also affordable, way safer in a lot of ways than our benzos, and really well tolerated. You also might have patients who are already taking this, similar to the TCAs, so this could be a really nice option. Here's some more information on gabapentin. I am going to, again, the relative safety is a really nice factor here. It is not good as a primary mood stabilizer, even though it is a good anticonvulsant. And let's see. Yeah, no efficacy as a mood stabilizer above placebo. Gabapentin's kind of interesting. Some patients, similar to beta blockers, sometimes it may worsen depression, so we want to pay attention to that. Here they're saying not recommended in most cases as a sole treatment. In my experience, I have a lot of folks who do really well with gabapentin, but it wouldn't be a first-line treatment. So I think that's fair. I also like the lower doses, right? So if anxiety, if we're using a whopping dose of like 2,700, 3,600 milligrams or something, sometimes 100 milligrams at HS can be great for sleep and anxiety. More stuff on the pharmacodynamics of it. I'm going to scroll through that. The main thing, I think, is just, you may need renal dosing because most of gabapentin is renally excreted. And don't give it with antacids. Side effects of gabapentin are like other GABA things: sedation, fatigue, ejaculatory problems. Allegedly, no one's told me about that with gabapentin, but the day is still young. And you want to titrate slowly and taper slowly if you can. Here's one potential dosing schedule for gabapentin. This isn't necessarily a manufacturer recommended version. This is just one where, again, it's going up slowly. More information on the dosage. Again, huge dose range. So if you can catch somebody at 300 milligrams, please don't prescribe them 3,600 milligrams. You can do really well with less of it. And that concludes this talk. I do think I'm a little bit over the time I intended for this recording, so sorry about that. But hope this has been helpful, and I look forward to seeing you guys again soon.